morning, and thank you so much for joining us here on the Morning Medical Update. I'm Jessica Lovell. It's winter, and just like many of you, we are working hard to bring you some fun and exciting programs in the coming weeks and months. This morning, we are bringing you a rebroadcast of one of our favorite shows. If you have any questions, please leave them below, and we will answer them during our live broadcasts on Mondays, Wednesdays, and Fridays in January. We'll resume our Monday through Friday live schedule in February, so sit back and enjoy this best of Morning Medical Update. Good morning. It is Thursday, September 22nd. I'm Jessica Lovell. So glad you're with us today. Ovarian cancer in women under 40 is relatively rare, but that was not the case for this woman who was diagnosed with stage 3 ovarian cancer at the age of 39. Her journey is now helping other women facing the same diagnosis. Dr. Dana Hawkinson will join us with the latest COVID-19 numbers and why it is still important to rethink those large gatherings. And you'd think fall would bring on all the good feels, all the good warm and fuzzies, but not for everyone. Those winter blues can be felt year-round, and there's a real reason why. That's all coming up next on the Morning Medical Update. Thank you so much for joining us this morning here on Facebook, YouTube, and on Twitter. A woman's risk of developing ovarian cancer is about 1 in 78 during her lifetime. For Holly Oldag, she is living proof that it can happen at any age. She finally found the right treatment plan and the right doctor, and they are both joining us here this morning. Holly joins us to tell us about her fight with ovarian cancer and how she's helping other women with her story. Plus, it's her doctor with us today, who she calls her lifesaver. Oncologist Dr. Lori Spuzak is joining us. Good morning to you.
Good morning.
And welcome.
Thanks so much for having us.
Yes. Good to see you both. And we want all of you to make sure you get your questions sent into us on YouTube, Facebook, and the Medical News Network. You can find links to all of those right there on your screen. But first, it has been called the winter blues. We've heard that before, but it actually has a real name, SAD, seasonal affective disorder, and it can happen year-round. Joining us to talk more about SAD is clinical psychologist Dr. Danielle Johnson. Dr. Johnson, good morning to you.
Good morning, Jess. So good to be here.
I know fall just kicked off. I don't want to be sad. So tell us why SAD affects people in the fall, spring, and in the summer. Is that true?
So what we know as seasonal affective disorder has been reclassified to major depressive disorder with a seasonal pattern. And for the 5 to 6% of the U.S. population that experience those symptoms, it comes in the fall and winter. So I've got on my burgundy to bring about fall because it's upon us. And for some folks, come fall, their mood starts to decline. And there's the very few percentage of folks that have it in the summer. And so we tend to think of the winter, darkness, less sunlight, which impacts serotonin production, which impacts melatonin production. And we also have decreased levels of vitamin D. So those factors account for what we typically call the winter blues or the seasonal sadness.
All right. So pumpkin spice doesn't just make everything better, is what you're saying.
Unfortunately not.
Okay.
Unfortunately not.
So this affects about 10 million Americans. That's according to researchers at Boston University. And women are 4 more times likely to be diagnosed than men. What's the reason behind that?
Well, we know from research that women are twice as likely as men to be diagnosed with depression in general. And so with that increased rate for women, we tend to see that the depressive symptoms that we see that are of a seasonal pattern would also hold true. So women are at higher risk. Another piece that impacts women that does not impact men as much is fluctuating hormones, specifically estrogen. And so estrogen does impact how we produce serotonin. So for women, we are at higher risk of having fluctuating estrogen levels, which impact serotonin, which then means we are at a higher risk of overall depression, but then also of the depressive type that has a seasonal pattern to it.
So what's reverse seasonal affective disorder?
So we talk about fall and winter and how difficult that is. And so there are, I think if you have 100 people that have seasonal affective disorder that impacts fall and winter, of that 100, about 10 people will have the summer variety, in which during the summer, they are irritable, they have decreased appetite, they may lose weight. And what we think is going on is, one, there's a lot of sun. So with more sunlight, we have less melatonin production, whereas in the winter, we may have increased melatonin production. So these folks aren't producing enough melatonin to induce some of the lethargy for sleep. Also, I think we could all living in the Midwest, the summers are hot. Summer is hot, very humid, and increased temperatures also increases mood. Or decreases mood. So we're more irritable. We're typically a little more cranky in the summertime. So if you're already at risk for mood fluctuations, and the summer comes and the heat, you're at risk. And what we find is the inverse. So for people that struggle in the summer, those people tend to live closer to the equator. Whereas for the winter and fall depressive symptoms, you're at a higher risk the farther away you are from the equator. So there are studies that look at people that live in Florida, the rate's like 2%. But you live in Alaska, the rates are as much as like 10 to 11%. So there's a number of factors that impact when and how we are impacted by weather, mood, and hormone levels.
Dr. Johnson, finally, just how do we know we have it and when should we seek help?
So when we think of depression, we think of those classic symptoms of sadness, crying spells, isolation, reduced interest in activities, hopelessness, helplessness. Those symptoms are all the same. And so we want to see that that's impacting your ability to live life, to go to work, to interact with others. Some people also have thoughts of suicide or death. And so if you're struggling with being able to function, that you know your mood changes every season, it changes. I actually have a patient who I only see in the winter. She has major depressive disorder with a seasonal pattern. And so we meet, we'll start probably meeting in the next month or so. We'll meet in the fall and the winter. And once spring hits, her mood does alleviate. She also takes medication that helps with that. But if you have a seasonal pattern to your mood where you know it fluctuates and you have a hard time functioning, please seek out treatment. And we know that medications help, we know therapy help, and we know light therapy also helps.
Very good advice, Dr. Johnson. Thank you. Interesting stuff. Good to see you. Have a great one.
You as well. Take care, everyone.
Well, ovarian cancer is the deadliest of reproductive cancers in women. According to the American Cancer Society, more than 20,000 women will be diagnosed with the disease this year, and nearly 13,000 will die from it. About half of the women diagnosed in those cases are in their 60s. But Holly, good morning to you. That was not the case. You were diagnosed with ovarian cancer right before your 40th birthday. Good morning to you, and thank you for joining us.
Morning.
So just tell us, just kind of briefly tell us what it was like when you first heard this diagnosis.
It was extremely scary and surreal. I had been sick for several years and I knew something was wrong with me, but my doctors just couldn't figure out what was going on. I was diagnosed with anxiety, fibromyalgia, GI issues, but it finally took, saw my endocrinologist and I told him, I said, I know this is not your area of expertise, but I'm having all of these symptoms and I really think something's wrong. And he sent me down for a CT scan and immediately got a hold of my gynecologist, who admitted me to North Kansas City Hospital, ran a bunch of tests, and came into my room at 2:00 in the morning on a Saturday and told me that I think that you have ovarian cancer. You're going to have a hysterectomy, and I'm not going to be able to do it. He said, you have to have the best of the best to do this surgery, so I'm going to send you to KU. So they sent me Saturday night to KU, and then Sunday morning I had surgery and had a complete hysterectomy at the age of 39.
You were sent to Dr. Lori Spuzak, who's with us here today. You went through 18 rounds of chemo. You took part in a national trial. Your cancer returned 2 years later, it was 2019, correct?
Correct.
How are you doing today?
Today I'm doing good. In 2019, with my recurrence, I did another 6 rounds of chemo, and then I started a PARP inhibitor, Lynparza, that I was on for 2 years. And I've been off of that now for almost a year. And I'm actually feeling the best that I have felt in the last 5 years.
Fantastic news. I want to bring in Dr. Spuzak because you say, doctor, that rapid advances in ovarian cancer treatments, they've had such a big effect that we're actually literally rewriting the statistics when it comes to women, their quality of life, how long they live, how they're responding to treatment. Tell us more about that.
Yeah, so right now, Holly is an example of how we are literally bringing years of research from the bench to bedside. Over the course of even Holly's illness, we have grown in our knowledge of genetics and how they impact cancer care. We have grown in our ability to target specific treatments to people's genetic background. And so these are all actively rolling out in the last 5 years. And so when folks come into me and ask me, what's my prognosis? I say, there's no way I can tell you. It is such an individual process now that depends on whether or not we're able to do a surgery, whether or not we're able to get you through your chemotherapy, how long until you have a recurrence after chemotherapy, what drugs we're able to give you as maintenance therapy, which is a new concept that is a bridge after chemotherapy that you stay on to prevent a recurrence. So literally in the last 5 years, all of these new technologies are rolling out such that it is impossible for me to tell a new patient how long they have. It's not possible anymore because the statistics and the technologies that we used to use are too old. And so we are literally rewriting history right now.
So this is all good news.
This is all amazing
all good news because
yes.
it's no longer one size fits all. I mean, the
right.
treatments are so specified
That's
to each
right.
particular patient. Holly mentioned PARP inhibitors.
Yes.
Is this a game changer in your opinion?
Absolutely. So about half of women with ovarian cancer have something called homologous recombination deficiency. And actually, all of this knowledge came from learning about one particular mutation in families called BRCA, and it's expanded to multiple other mutations. And in fact, Dr. Jensen, the head of our cancer center, had a role in the discovery of this whole gene process. And what it has evolved into is our ability to target homologous recombination deficiency for our patients with cancer. And it is extending their time without cancer. And in some cases, now we're starting to see trials results where it might be impacting our overall survival for patients as well. So these are things that are totally new and have finally moved from the research to the bedside. And we're really seeing them play out for patients in the most fantastic ways. Yeah.
Dr. Suzak, Holly has credited you with saving her life. She was just 39 years old. And I have to say, I love it when I hear people say that they were at one hospital, and that one hospital, no ego involved. They said, we want you to go to the best that you can get.
Yeah.
And that was here, and that was with you. And so I love that part of your story, is that, you were sent here for a second opinion.
Yeah.
But when she came to you, there was a lot to sift through. So how do you, in that instant, and she was brought in quickly for that surgery, how do you help her navigate those options? I mean, there's such an emotional component to it, but you also have to get her in. So
Absolutely.
How do you go through all that with Holly?
When someone's 39, we try to move as fast as possible. There are a lot of things we do in looking through someone's scans, their exam, tumor markers in their blood, to decide how urgent surgery is. And then from there, once we get that pathology, how we quickly move toward a treatment plan. And even the treatment plan that someone gets now for their upfront surgery might be different than even what Holly got at the time of her surgery. For example, now we have even a new process called heated intraperitoneal chemotherapy for certain candidates who are able to go through a total it's called a cytoreductive surgery, where we remove all their cancer. So there are so many factors that go into that decision making. Sometimes folks are not eligible for an upfront surgery. They need chemo first before that they'll be able to have a safe surgery. So there are so many different strategies now that we employ. It's there's a lot on the table, but what we know is in a young person, we want to try and move as quickly as possible so that we can get them the treatment they need as soon as possible, because time matters for ovarian cancer. And I also want to point out that it is critical that patients go to an NCI designated cancer center for their care. I can't stress this enough, and that is because you will receive the most cutting edge care. I think folks in our community don't quite understand that the care you get at KU is a parallel to the care you might get at Mayo Clinic or MD Anderson. That is the caliber of research and the board certification of not only the surgeons, the medical oncologists, the pathologist. It's an entire complex of care that you're getting here that is unique, and it's extremely important to seek care here.
I want to ask you about this particular type of cancer. Is it hard to diagnose as it is to be detected? I mean, with the signs, they're hard, they can be missed.
Yes.
What should we know?
So ovarian cancer many times presents at a late stage because the signs are very subtle. There is no screening test for ovarian cancer like there are for cervical cancer, for example, or breast cancer. Many times ovarian cancer explodes. It goes from 0 to 100 within several months, and so it's very difficult to predict if someone's going to have an ovarian cancer. And we've done a lot of different things to try and do that. Tumor marker testing in the blood, serial ultrasound exams, and actually none of those for the general population has led to a viable screening test. The things that we have now that sort of allow us opportunities to intervene earlier are genetic testing. So for those who have a family member who has had an ovarian cancer or sometimes a breast cancer and they get genetic testing, now we're able to intervene much earlier for those folks who are affected by familial syndromes with cancer. And in that way, we are able to start intervening earlier with different strategies.
Holly, I want to ask you about the trial you took part in. Tell us about that decision to do that and how successful was it?
The trial that I took part in, it was actually for a PARP inhibitor. But this was 5 years ago, and that was pretty new. And so I did my treatment, and then I started the PARP inhibitor. I was on that for almost 2 years when the cancer returned. But we found out after the cancer came back that I was actually on the placebo. But that was the very beginning of when the trials for the PARP inhibitors were coming out.
Trials are so important.
They're really critical. And so actually, what Holly contributed to was the knowledge that we can use PARP inhibitors in the upfront setting. So while Holly didn't benefit from a PARP inhibitor upfront, what that trial proved was that actually women who get PARP inhibitors after their upfront treatment actually end up having a longer progression-free survival. And so while clinical trials, there are arms where you are comparing standard of care plus a placebo to standard of care plus a study drug. That is life-changing for future generations of women. And then we were able to subsequently use a PARP inhibitor with Holly after her recurrence.
So I want to weave in and make the leap over to COVID, because this mentor program that was started among your team during COVID really served this population of women needing to get in contact with each other. So I want to talk to you, Holly, a little bit about how you are mentoring other women and what you're also getting out of the program.
Yeah, definitely. Whenever I was first diagnosed and I reached out into the ovarian cancer community, most of the women that I talked to were in their 60s or 70s, and their experience with ovarian cancer was much different than mine because I still had young kids at home. I still had a lot of different things to try to navigate. And so when Dr. Spuzak reached out to me to do the Women to Women mentorship program, I was so excited to be able to talk to people and help them just go through, navigate just the different emotions and feelings that you're going to have. Sometimes I'm just there for these mentees just to listen to them. I mean, they can call me anytime, day or night. They can cry, scream, laugh. I'm just here to just be a guide who understands exactly how they're feeling. They can ask me questions that they don't feel safe asking other people. And so I'm just so thankful I do this because it's not just them getting something out of it. I get so much reward being able to help other women just navigate this.
Dr. Spuzak, I would imagine that to be a very effective tool when one woman who's been recently diagnosed to just hear Holly on the other end and see where she has come today has got to be really powerful.
Absolutely. I feel like there's only so much I can say. I haven't lived the experience. And so for someone who has in their body lived that experience of the first day of chemo, of getting a port, of walking through that journey with their family and how all of the changes in their body, and then getting back to normal life after their treatment is completed. The Woman to Woman program has radically shifted the way that folks are able to navigate that journey. We want you to know that you are never alone during that journey now. You have the opportunity for support. And Holly also participated in creating videos that are these incredible monuments to how we can talk to each other and teach each other from the experience of the patient, of the mentor. And they are this whole suite of videos that we have on our website at the Cancer Center under the Woman to Woman program. So Holly has done incredible amounts of work supporting women in all of the ways.
Let's take a quick break and check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, sharing our COVID numbers this morning. Good morning to you.
Hi.
Hi.
Yeah, here in the health system, we still have 33 active infections, with 3 in the ICU and 2 on the ventilator. We still have 20 in that recovery period as well. So our numbers are holding fairly steady. And again, as we know, as the national numbers are decreasing. So overall, that is a good thing, and we know that boosters are available. So if you are needing to be up to date with your booster, again, would encourage you to go get that.
All right, Doc Hawk, the Danish Queen tested positive for COVID the day after Queen Elizabeth's funeral, a very large gathering.
Yeah.
So should we be reconsidering attending those large events? I mean, whether it be going back to masking or just reconsidering if we even show up or not?
Mm-hmm. Yeah, I mean, again, I think at this point in time, you really have to take your own risk into account and understand the risk that you are going to be going into in any situation. The first thing is obviously be up to date with your boosters, as I alluded to a minute ago. The other thing is just understand the context and that environment that you're going to, how many people are going to be there. Is it going to be outdoors or in a very well ventilated area? And of course, you are always welcome to wear your mask and do that appropriate frequent hand hygiene as well. And that all of that will help reduce your risk, but just understand your risk of contracting the disease and what would happen if you do. Certainly if you are in that older age group, so say 60 or over, and you are getting symptoms, it is important to test early and then discuss with your medical team, and if you need to, get on Paxlovid for sure, and that will help reduce your risk of hospitalization as well.
A new study by the World Health Organization found that COVID-19 reduced contraceptive access. How is this affecting the sexual health of the nation?
Yeah, I mean, again, I think this is one more point to look at when we talk about what are some of the things that COVID, what the pandemic has interrupted and decreased. Certainly we know that vaccination campaigns, other public health campaigns have been reduced as well. This is just one more issue that has been that we have seen a decrease or falling off since the pandemic began as well. It's just one more point to drive home the fact that COVID has affected all of our lives in many, many different ways.
Okay, so on that note, a 26% rise in new syphilis infections, that was reported last year. It's now prompting U.S. health officials to call for new prevention and treatment efforts. Yeah. So can you kind of help put that into perspective, that 26%? It sounds high. Yeah. Kind of help us understand what that means.
Yeah, I mean, again, another point. However, even before the pandemic, we knew that we were seeing a rise in sexually transmitted infections, including syphilis. I know that in my practice and with my ID colleagues and partners in our practice, we have seen a significant rise in the amount of cases that we're treating of syphilis in general. But we know those things are continuing to rise, and I think this plays into the bigger part of what I was saying. That public health and that public health infrastructure, and we need to continue to give funds to the public health resources so that we can help really stave off these things and decrease their numbers, because it can affect people. It can affect your health. If you are a mom who's pregnant or becoming pregnant, certainly we know congenital syphilis can largely affect babies in the womb as well. So overall, it is a national public health issue.
Dr. Hawkinson, thanks so
Yeah.
much. Let's check and see if we have any reporters on the line today. All right, let's get to some great community questions because we've got some. Joellen wants to know, Holly, you had said that you hadn't been feeling well for several years. Can you again describe those symptoms that you were having that led up to you asking more questions of your doctor?
Yes, definitely. I had a lot of bloating. Anytime I ate, I would get extremely bloated. I had really bad lower back pain. I had to urinate frequently. And towards the very end, I started having menstrual changes. And I just didn't feel well. I was just fatigued. Like when you're very first pregnant and you're so tired, that's how I felt all the time.
Holly, you just described, I think, how most women feel. Tired all the time, but work through it. Pain, bloated. I mean, hello. I mean, I think that describes almost every woman over the age of 40 sometimes, Dr. Spuzak. It makes it really difficult because women, we talk about men working through the pain a lot and not going to their doctor, but I think women are just as guilty of saying, hey, I can shake this off.
So I agree with you to a point. So I think the important thing here is that the symptoms didn't go away.
Gotcha.
And so we can't ignore, no matter what our age is, yes, the most common things being common for a young person are not going to be ovarian cancer, but we can't let that go if the symptoms don't go away.
So that brings me my question. So, okay, you have the occasional bloating. Is it longer? Is it more constant? Is it over several weeks? When do I need to pick up the phone and get to my doctor?
I would say that after several weeks, if your symptoms are not going away, no matter what it is, for sure you should get into your primary care doctor. But also, I 100% advocate that every person of reproductive age has a health exam once a year. And I think that a lot of younger folks ignore that. And so it could be a reproductive health exam, it could be with your primary care doctor, but for sure that you get an exam, because there's so many things that the way that we know something's wrong is that we compare it to when it was fine or right. And so it's really important that you consistently see your doctor.
Don't just accept that you don't feel well. And
That's
this is,
right.
And this is normal.
That's
it's not
right.
normal.
Yeah.
And it's okay to ask questions.
And keep pushing. I think Holly is a really good example of that. Yes, you have to keep pushing because there are times when you are the only one who knows that this is not right.
Isaac has a question. Holly, for you, is the vaccine working well for you? Were you vaccinated and how was going through this during a pandemic?
The COVID vaccine? Yeah, I was vaccinated. I got all my boosters. It was kind of hard to go through this during COVID because I had already for 2 years prior really limited where I was, what I did, because I was immunocompromised. And when COVID started, I was on the PARP inhibitor still, so I was even more compromised. So I had to be really, really careful what I did. So my life was kind of on pause during all of that time. But I mean, on the bright side, during COVID, my kids were home. My future daughter-in-law was here with us. So I got time to be with my kids. So that really worked well for me.
Finding those bright spots, those positive moments during this time. Juan wants to know, Dr. Spuzak, is it possible to prevent ovarian cancer?
So I'll say yes, and it depends on a couple of different things. So any person who is of reproductive age taking an oral contraceptive pill or anything that stops ovulation can reduce the risk of ovarian and uterine cancer by about half.
So birth control pill.
Birth control pill. So it depends on, so all that effect of risk reduction has to do with how long and how consistent you are using that. But so that could be for in the general population, the risk for ovarian cancer can be nearly cut in half.
So would you recommend that for somebody who has a history of it?
Who has a history
so
of...
So if a patient has a history in their family of ovarian cancer, would you put them on a birth control pill?
Absolutely, that would be part of our risk reduction. Also, we would encourage that person to get genetic testing. So genetic testing for anyone who has a family member that has a history of an ovarian cancer, pancreas cancer, that's a first-degree relative, for sure they should get genetic testing. And then that genetic testing, whether or not they're positive for any number of known mutations that we have today that we're aware of actually modifies that risk and how aggressive we are with different recommendations for risk reduction. So some risk reduction efforts are about the frequency of exam, ultrasound, CA-125. Some are about taking a combined oral contraceptive pill to decrease ovulation. Some are about a risk-reducing surgery to remove fallopian tubes and ovaries. So actually we have a number of strategies, but it depends on what your family background is and then also what genes you may carry.
Okay, Juan also wants to know, are there indications of stem cell therapy in ovarian cancer?
Not that I am aware of currently. Okay. For ovarian cancer treatment. Yeah.
Okay, and then Joellen wants to know, how is ovarian cancer diagnosed? You may have mentioned it, but I just clear that, please, for me.
So ovarian cancer is a diagnosis of pathology, meaning we must remove the organ, the ovary, or get a biopsy of that organ to confirm that it's a cancer. Simply having a pelvic mass is not enough because many times you can have a tumor, but that tumor is benign. And so we need to actually remove that tumor to test it under the microscope to see what it is.
A couple more questions. Edna wants to know if there's a vaccine or something on the horizon for ovarian cancer, the way the HPV vaccine is for cervical cancer.
So not in the same fashion of an HPV vaccine. So HPV vaccine, I can't sing the praises of enough. The current version of the HPV vaccine decreases the likelihood of getting cervical cancer by 99%, which is unbelievable. I wish we had something for ovarian cancer like that, and we do not have that technology for ovarian cancer.
Blair recently read an article that alcohol has been linked to several cancers. We've heard that before. Any direct link to ovarian cancer?
So there's no direct link to ovarian cancer, but what I would say is that for any cancer, maintaining a healthy lifestyle, including exercise, weight management, an appropriate diet, globally will make you fit in a way to, if you get a cancer, receive treatment in a different way, tolerate treatment, tolerate the burden of side effects that come along with treatment. And so globally, there are many cancers that are associated with changes in your overall health status. And while alcohol is not one thing that's directly linked to ovarian cancer, for sure, lifestyle changes can absolutely affect your ability to reduce cancer globally. And then also, if you get cancer, to tolerate treatment and whatever that looks like, surgery, chemo, radiation therapy.
Before we get to our final thoughts, Holly, I want you to tell us about Camp Make a Dream. I was trying to reach you, and Dr. Spuzak said, oh, she's up in the mountains of Montana, and she's unreachable. So tell us what you were doing up there.
Yes, Camp Make a Dream is a wonderful camp. They have retreats all summer for kids who have cancer or families dealing with cancer. But in the fall, they have a specific ovarian cancer camp, and all of the women there have ovarian cancer or have had it. And so to go and to be able to connect with all of these women and share our stories, it is something I cannot promote enough. And I just wish everyone knew about it. It's free. All you have to pay for is your flight to get out there, but it's completely free. And it is an experience that I wish everyone could go through who is going through this cancer. It is absolutely amazing. And the friendships that I've made there are lifelong friendships.
Camp Make a Dream. I had not heard of it either, so thank you for sharing that. I'm sure people appreciate knowing that it exists and that they can take part in it as well. I want to get to final thoughts, and Holly, I want to start with you. I know that you really kind of started counting life through your milestones. Your son your big thing was to be able to be at your son's graduation. You were. Now you're going to be hitting your daughter's graduation. You're going to go to your son's wedding. Just tell us how life looks for you these days.
For me, ever since I had my recurrence especially, I plan my life in 6-month increments, from scan to scan until I know everything's okay. And then for 6 months, I know I'm good. But I have everything in milestones. My original goal was, yes, to make it to my son's graduation. Now he will graduate from the police academy in December, so that's my next goal. My daughter graduates high school in the back in the spring, and then my son is getting married September of next year. So for me, that's how when the things are really, really hard, I just put those goals in my mind. I'm going to be here for this. I have to be here for this. And so that's how I get through the really rough days, is just knowing I have to be here for all these big things in my kid's life.
Well, to tell you the truth, Holly, we should all be living our life that way, taking a moment and being present and just taking life day to day, 6-month increments, as she said, scan to scan, Dr. Spuzak, and kind of makes us stop and think how we live. So we appreciate you, Holly, for sharing your story, and stay in touch with us, okay?
Thank you so much for having me.
You bet. Dr. Spuzak, final thoughts. What you always have brilliant words to leave us with.
Our parting words?
Your parting words.
I think that I'm so excited for the future of cancer care in general, but for 2 reasons. One is, yes, we are seeing cures in ways that we never have, and we just saw a publication this morning about that cancer death rates are decreasing overall, so people are surviving longer. I think that another important thing to talk about is that also cancer care is turning cancer into a chronic disease in a way that we've never thought of before. There's an entire space between cure and dying where people are living for years and years and years for unpredictable amounts of times, and we need to support them in that space and also give voice to that group of people because I think that there's not enough knowledge of that fact, and that a lot of our new technologies for cancer care are actually making room for this entire growing group of folks who are living with cancer as a chronic disease. And part of that is what Holly is doing with milestones and thinking about future planning and having hope for the future while we're dealing with cancer in our bodies. And so I have hope in many different ways, not just in a hope for the cure, but a hope for a way that we can continue to support people for wherever they are in their disease journey.
I love sitting with you, and I know very few people who are as big of an advocate of women's health than you, so you're much appreciated. Please come back.
Thank you so much.
And I know you've got a couple of people that just started in your practice too, right?
Absolutely.
Because you've been very busy over the last couple of years.
Yes, we have. So Dr. Jewel and myself are here, and we are being joined by Dr. Melissa Havliana and Dr. Ian Cook, and we couldn't be happier to have them join our practice. So we are continuing to grow at KU, and it's a great place to be.
Thank you, Dr. Spuzak. Dr. Hawkinson, final thoughts today.
Yeah, I'd like to echo the part about the vaccines. Obviously, we talked about the HPV vaccine and its incredible ability to help protect you against cancer. I think this goes to all vaccines and really public health and your individual health. Remembering to stay up to date with your vaccinations, not just COVID vaccination, but obviously everything. Talk with your physicians, talk with the pharmacists at the local pharmacies. Really get that done. That will help protect you, most importantly, and then, of course, your community as well.
I have to ask Jeannie's question, Dr. Spuzak. She asked if the risk of ovarian cancer decreases as you start menopause.
Actually, the risk of ovarian cancer basically increases. So, or in the sense that overall, as you age, your risk of developing an ovarian cancer is higher.
Okay.
I guess I would say that.
Okay.
Yeah.
Jeannie, thanks for jumping on here at the last minute. Appreciate you.
Subscribe to our morning medical update and open mics with Dr. Stein's podcast. Now, everywhere podcasts are available.